Good morning, good afternoon, good evening, wherever you're joining us throughout the world. Uh, Welcome to this HCC's webinar on NCDs. Don't pause during disasters. How do we strengthen preparedness, response, and recovery in the Caribbean region? Thank you so much for joining us, especially if you are in the Caribbean. But if you are not in the Caribbean, thank you for showing your interest because climate affects all of us, and we should all be part of this conversation. I am Kenneth Connell, the president of the Healthy Caribbean Coalition, and I will be your moderator for today. So I'm just going to first of all, thank our partners, the Caribbean Public Health Agency, the OECS Commission, Pan American Health Organization, and Earth Medic, Earth Nurse. And James Hospitalis will say a lot more about that. And I'm just going to deliver a few remarks to kind of, I guess, whet your palate, literally, for what's up to be an exciting webinar. So the Caribbean is one of the world's most disaster-prone regions, especially at this time of the year. Climate-related events, as they become more frequent and certainly more severe, we are reminded that disasters are not only environmental or humanitarian crises, they're also public health crises. And for millions of people in the region living with NCDs, disruptions in healthcare, medicines, healthy food, safe water, physical activity environments, and of course, mental health support can quickly become life-threatening, or at least shift the way we live our life from day to day. Today's discussion, therefore, recognizes that disaster preparedness and response must extend beyond immediate relief. I want to repeat that. Today's discussion recognizes that disaster preparedness and response must extend beyond immediate relief. We must ensure that NCD prevention and control are embedded in every phase of disaster management, before, during, and after emergencies. So throughout the webinar, we will explore a wide range of health topics, climate-related disasters, hear from, of course, our partner organizations and experts leading preparedness and response efforts throughout the region, share practical resources, including HCC's donations protocol, you don't want to miss that, and resources developed to support people living with NCDs, and of course, identify concrete actions that will strengthen resilience across our communities. Conversation also reflects HCC's broader advocacy priorities and demonstrates how they intersect with disaster preparedness and resilience. We also call for greater investment in preparedness that recognizes the interconnected challenges of climate change, food and nutrition, or should I say healthy food and nutrition security, alongside sustainable financing and accountable mechanisms that help countries build resilience before disasters strike, not simply respond to them once they have occurred. So today's webinar then is an opportunity to learn from one another, to strengthen partnerships, to reaffirm a simple but critical message. Disasters may be unavoidable, but preventable suffering is not. So together, let's ensure that people living with NCDs are not left behind when disaster strikes. Once again, thank you for joining us on behalf of the entire HCC family. We are excited to have you in our home and for our webinar this morning. And now I'm going to invite some of our key partners to begin with their opening remarks, starting, of course, with my colleague, Dr. Heather Armstrong. Heather, baton over to you.
Thank you, Dr. Connell. And good morning, colleagues, partners, and friends. The Caribbean Public Health Agency, PARFA, is pleased to be part of this important webinar. Alongside with the HCC, PAHO, OECS Commission, CDEMA, Earth Medic, and Earth Nurse. And surely this discussion is timely and urgent. Across the Caribbean, NCDs remain the leading cause of illness, disability, and premature death. During hurricanes, floods, and other emergencies, risks increase significantly. Medicines may run out, health facilities may become inaccessible, healthy food may be limited, and routine care may be interrupted. At the same time, psychological stress increases and mental health conditions may worsen. And that is why CARFA continues to advocate for the full integration of NCDs into the disaster preparedness response, and recovery systems at the national level. These areas cannot be treated as add-ons. After an emergency begins, they must be built into preparedness planning from the start. And through the Caribbean NCD Nutrition Mental Health Focal Point Network, CARFO works with member states and partners to strengthen regional coordination and support practical action. The network has identified 9 priority areas, such as integrating NCDs into emergency policies, ensuring NCD-ready health facilities and shelters, strengthening continuity of care and medicines, embedding mental health and psychosocial support, applying nutrition standards in emergencies, improving communication and early warning systems, mapping and engaging stakeholders, expanding responsible private sector partnerships, and securing sustainable financing. Preparedness must ensure continuity of care. If we are serious about resilient health systems, then NCDs must be included in every disaster plan, emergency protocol, and recovery strategy across the Caribbean. We look forward to an engaging discussion and to collective action that better protects people living with NCDs, before, during, and after disasters. Thank you.
Thank you, Heather. And passing the baton over now to Roxanne, the OECS Commission. Roxanne, which territory are you located in?
I am in St. Lucia.
In St. Lucia, so right next door. Go right ahead.
All right, thank you, Dr. Cornell. Good morning, everybody, and greetings from the OECS Commission, the Director General, the Head of the Human Social Division. It is really an honor to partner with our colleagues at HCC as well as our regional health agencies on this vital and timely conversation. Today, we confront the stark interconnected realities of climate shock, natural disasters, and NCDs affecting the people of the region. To this end, the title of this webinar could not be more appropriate. We have seen the crippling effects of numerous hurricanes across our islands. And while we are highly susceptible to natural disasters, they are not the only crisis that we face. Naturally, when these climate disasters strike, our immediate focus pivots to life-saving search and rescue, clearing roads, restoring power. But while our emergency services are running at full speed, a silent crisis continues to unfold in the background. We are witnessing a staggering increase in our chronic non-communicable diseases, a crisis that is no longer an adult problem, but one that is affecting our children, our youth, and our workforce. The data is very clear, and this is not just a health statistic. It represents the loss of human capital and a profound threat to the economic stability of our member states. When a disaster hits, our health infrastructure, nutrition, and access to safe, healthy foods are immediately compromised. Furthermore, the profound psychosocial toll and acute anxiety left in the wake of these storms heavily compromise our regional mental health. These interconnected crises threaten our health systems, our economies, and our social fabric, fundamentally disrupting our entire way of life. So in confronting this reality, our actions must be targeted. This is why tools like the Safeguarding Public Health Nutrition Guidelines and disease-specific patient brochures are so foundational. As we navigate yet another unprecedented hurricane season and evolving climate landscape, the OECS Commission, in alignment with our mandate of regional integration and our strategic priorities, we remain firmly committed to working with our partners. Together, we must structurally integrate NCDs management and mental health support directly into regional preparedness, response, and recovery frameworks. Disasters do not pause for NCDs, so our policies, our preparedness, and our collective action cannot afford to pause either. I look forward to the actionable insights and recommendations that will emerge from today's panel. Thank you, and I wish us all a highly productive webinar.
Thanks very much, Roxanne. And over to our partner at PAHO WHO, Leah. Can you hear me? Go right ahead.
Good morning. Good morning, everyone, and thank you again for the invitation. So, greetings from the PAHO Sub-Regional Office for the Caribbean based in Barbados. And today, PAHO's message is simple. Disasters don't create new health problems. Instead, they expose and accelerate existing ones. And so when we talk about disaster preparedness from the perspective of meeting the needs of persons living with NCDs, we talk about maintaining the continuity of care. In a disaster, interrupted care becomes a life-threatening event within days, not months. And so the 70 to 75% of deaths in the Caribbean, which are driven by NCDs, means that in all disaster preparedness plans at the national, subnational, and community level, need to recognize the needs of persons with chronic conditions.
Mhm.
These plans should have a clear mapping for persons with NCDs of where to access care if their regular facility is closed, including, for example, telehealth and telemedicine options for when electricity is restored. And persons with NCDs should be able to secure an extended supply of their essential medicines and should already have been mapped to a community health worker for continued follow-up while health facilities are being restored. These are just some examples of what we call climate resilient health systems, which include networks of health facilities, supply chains, and even information systems that keep functioning under stress. These are central to PAHO's work with ministries of health and partners across the Caribbean because they highlight the fact that continuity of care for people living with NCDs has to be treated as a core measure of a health system's disaster preparedness. PAHO and WHO already have the tools for this, and we have been working with countries to not just have them developed, but to test them and to apply them so that they are more and more prepared each year for when the eventual hurricane, storm, or natural disaster strikes. With these words, we thank you again for this invitation. We think that this webinar is more and more valuable in terms of the discussions that we will have today, and we hope that countries will be more and more prepared each year in preparation for the hurricane season. Over.
Thanks, Leah. And our final stakeholder from Sedema, Mr. Mandela Christian. Mandela, you're all here. Okay, great. Go right ahead.
Yes, we are. And thank you very much, Dr. Cornell. Good morning, colleagues and partners. On behalf of the Executive Director and team at the Caribbean Disaster Emergency Management Agency, I want to extend thanks to the Healthy Caribbean Coalition and partners for convening this timely conversation as we advance into the 2026 hurricane season. To reiterate the point from PAHO, disasters do not create vulnerabilities or new vulnerabilities. They expose and deepen existing ones. And for the persons affected by NCDs, disasters are not only a threat to property, it is a threat to continuity of essential life-sustaining care. CDMA's approach is anchored in comprehensive disaster management, or the comprehensive disaster management strategy, which is a holistic approach towards disaster management that not only focuses on the immediate effects and response operations post-impact, but also the preventative, mitigative, preparedness, response, and recovery actions. The lessons learned from recent events such as the COVID-19 pandemic, Hurricane Beryl, and Hurricane Melissa are clear. Protecting people living with NCDs cannot begin with or when the disaster strikes. It must be built into how we prepare, respond, and recover together as a whole of society effort. We look forward to engaging discussions during this webinar, and I would like to reassure you that CDMA remains committed to that partnership. Thank you.
Thank you very much, Mandela. So everyone, I know that you can give us a thumbs up if you're still very clued in and we've vet your palette sufficiently to move into the next section. I'm looking at the thumbs up. I'm not sure I can see the thumbs up, but James, I can see you. And I'm so excited to pass the baton over to you. But here's what I will say before passing it on. Yesterday, I said, and you can relate to this, to the clinical team, yeah, look, we are managing events, which are important. And I was referring, of course, to heart attacks and strokes, right? And Daniel, I know you're shaking your head. But what are we doing about the climate? And of course, back then I was speaking about risk factors for these events. So as much as we focus in on preparedness for events, how are we mitigating the climate that's changing? And with those few words, I'm going to turn my camera off and hand it over to you, James and Danielle, to continue this exciting session. Over to you.
Thank you. Hi, Danielle, again. Good morning.
Hi, Dr. Hospitalis. I'm excited to have this opening conversation with you.
Thank you. And thank you to Healthy Caribbean Coalition. We're happy to be partners in this very timely and relevant webinar, NCDs Don't Pause for Disasters. And we'll be unpacking that in more detail. My name is James Hospitalis. I used to be the director of CARFA. I used to be on the PAHO disaster response team many years ago. I've seen how the disasters have evolved, the more wicked hurricanes we have that strengthen faster, hit harder, last longer, they're wetter. Every which way, they cause more damage to people's health and well-being, to property, to businesses, etc., etc. All the determinants of good health get impacted upon by these disasters. It's not only hurricanes, we tend to focus on those, but you can have extensive repeated floods, unrelenting, and that's a disaster because of what it does to people's health and communities. And you could have, as Guyana experienced, and I must draw attention to this, 5,000 square miles of Guyana burned in wildfires in 2024. That's 30 times the size of Barbados. That's 2.5 times the size of Trinidad. So when you think of the displaced people, the food supplies, the asthma that must have been triggered, I got a lot of complaints. It's another kind of disaster. It's not actually on our radar, but Guyana is part of the Caribbean and part of the northern Amazon. So some of their disasters play out a little bit differently than us. So Daniela, we're going to turn our attention a bit to Hurricane Melissa, which was unprecedented, record-breaking, like so many of the newer storms we've been seeing, going back to Dorian and Irma and Maria. And I want to focus the question and discussion with you around young people and how were they affected? You worked along with a lot of them. What do you think, when you think back to those conversations, what do you think most about how the hurricane affected their daily lives? What did you hear? What did you see? And I mean, infrastructure is important, but people is what I want you to talk about, and young people.
Thank you so much, Dr. Hospitalis. Yes, so hi everyone, pleasure to be here. Of course, I am a part of the PAHO Youth for Health group and a very happy member as well of the Healthy Caribbean Youth group. And in some of my work after Hurricane Melissa, I would have recognized that there wasn't as much, there weren't as many spaces for us to hear about the youth perspective on how we're being impacted by the hurricane. And so I had worked with Television Jamaica to do kind of a documentary styled interviews. And so we went across the island speaking to young people in particular about the emotional impact as well as the impact on education, schooling, and how you view your future going forward. And one area I recognized is, the national conversations was so much dominated by infrastructure and roads and the damage to roofs and electricity, etc. But in every interview that I had with young people, one area that kept coming up was the emotional weight. And that's something you can't always photograph or capture in, figures and numbers and statistics. But it really was something you could feel that young people felt. In one interview, for example, a young lady said to me that, she was able to return to school. And so she was like, school now becomes a distraction from all of the, devastation that she's seeing, at home, or in her communities. And that's something that really, I would say, stuck with me. And I'd love to also just highlight a quick snippet from one of the interviews that I did. So you can also get a chance to hear, directly from young people. So let me just play this here and make sure that you're able to hear. Yeah.
Need to leave or evacuate or something. The windows were vibrating. The pressure of the hurricane was really scary. I remember my ears were hurting because of the pressure and the wind was non-stop.
Driving and seeing the damage caused, driving and seeing all the forestry gone, buildings destroyed, and a place that I call home just becomes something so unrecognizable. It's like I'm here and this is home, but it's not home. And I have to readjust, but I don't know where to start. I don't know where the road is ahead. So it's just really confusing and a really devastating time.
So we kept hearing that narrative kind of being repeated over and over, that home no longer looks like home, whether that is physically or, where you live with your parents, family, guardian, etc., or, school now looks different, and it's just hard to see my community and so on in so much disarray. So I think the emotional weight, I'd say, Dr. Hospitalis, was a big piece coming out of these interviews. And I'll go over to you now, Dr. Hospitalis, because I know you do a lot of work in this area, as you've mentioned as well. And so for you, when many people think of a hurricane, you think of an environmental issue, but you often speak about it as a health issue. Why is it important for us to view climate-related disasters through a health lens?
Well, that's a good question. And go back 4, 5 years, 6 years when we started Earth Medic and Earth Nurse Foundation for Planetary Health, and see the whole Earth is gripped in a hurricane of change, and the exposures that we have had for thousands of years are changing and changing rapidly because of continued use of fossil fuel. So bear with me. I'm looking at the causal chain, how health gets impacted, and that's causing more heat, causing more precipitation. When it does rain, it rains really heavy, bigger storms, sea level rise. All these things impact infrastructure. They impact air quality. So NCDs can also be affected. And then you have the outcomes, especially after big hurricanes. When I was on the first disaster response team mission actually my first was Jamaica, and that was an amazing event. And then can't imagine what Melissa as Category 5 would have done. That shows part of how things have changed. And you saw extensive damage to not only roads and bridges and so on, and communications, but health facilities. Inaccessible health facilities, sometimes destroyed. And that out of that whole experience was born the PAHO Climate Smart Hospitals program, which is a very good solution we should all be advocating for. And so you start to see that access to healthy food gets impacted. You have direct health impacts from injuries, drownings. Early warning systems help to prevent that or help people to foresee it. And of course, if you have a non-communicable disease, we realize now how much more vulnerable people can be to the heat, to the extreme weather, being on certain kinds of medications, and then the exposure to these conditions and how they change things. Shelters, sometimes schools are shelters to make a bridge to what you were saying, and then kids may not be able to go back to school even though it's functioning. So lots of different ways in which climate change and the exposures are changing the environment, and that impacts people's health, impacts their housing, impacts their livelihoods. All the determinants of health get affected. So that's I hope that helps to encapsulate some of the challenges to people's health.
Definitely. I think that gives a good overview, especially as, again, people normally view this as something structural, but not recognizing that it's basically a domino effect that, of course, can impact health in so many different ways.
And I wonder if you could comment on what you've seen as I've been speaking about determinants, access to healthy food, opportunities for physical activity. I mean, if you start to talk about disasters, you realize that automatically tends to be constrained. So how do you keep promoting that? Other things and the other things that support health and well-being after disasters?
For sure. So many young people would have lost access to fresh food immediately, right? And so if you're even connecting that to, for example, low availability of electricity, for example, to be able to power your fridges to keep your food fresh. That was a major area because electricity was gone for quite a bit of time across the island naturally. You also saw, damages to some of our farms, like our breadbasket parish of St. Elizabeth was really heavily impacted. And this would have been the second, well, not even second time, but it's a second hard hitter after the previous year where we had Hurricane Beryl also impacting our breadbasket. And that directly impacts our entire food supply. So even going into the supermarket, they started putting up signs to say, you can only get 1 carton of eggs, for example, because they're trying to make sure it's equitably distributed and things like that. And as you mentioned about, physical activity and so on, in one of our interviews, the young man said that when he was in Westmoreland, which was the area that was heavily hit, and he said when he went to stay with his family in Clarendon, he could hear kids outside playing, running around, and having that physical activity. When he goes back to Westmoreland, it's just completely silent. There's no movement. And that also plays in the psyche of a young person as your childhood, they're supposed to be so excited and happy. Like it looks very different for that period of time during recovery. And you even have some changes then in terms of household roles, where we still have young men who have not returned back to school or the education system after the hurricane, because they now had to become providers to help put food on the table for their family, because maybe their parents may have been, maybe their parents' job was impacted, or any other host of reasons. So there's a lot that's happening all at once, and there were many young people who are saying, you know what, I didn't realize I took all of this for granted. School, life, electricity, water, bread, because bread was also something we couldn't get in the supermarkets for a while. And so all of this then, of course, directly also impacts our young people's mental health. So a lot of different areas surfacing there. So I think then we can maybe go into, one of the themes for today's webinar is around NCDs, and of course the fact that this does not cause during disasters. So can you help us to understand what a hurricane can mean for someone living with diabetes, hypertension, asthma, or another chronic condition?
Thanks. It was 10 years ago, 2016, I wrote a paper for the G16 that was taking place in Buenos Aires, jointly with Prime Minister Harris, who was our lead Prime Minister for Health and Human Development in the Caribbean. And it spoke to NCDs and climate change being two sides of the same coin. And one of the ways in which that is manifest is the undue impact on people with NCDs following a hurricane. There tends to be a focus on 33 people died from the disaster as happened after, which was terrible, after Tropical Storm Erica in 2015. In Maria's at Jamaica, Puerto Rico, 64 people died in the storm. But in the months that followed, how it was measured and researched after, one realized that happened as many as 2,000 people over and above who normally died in the few months after. When you looked into what the causes of deaths of those folks were, perhaps not surprisingly, heart problems, chronic kidney disease, diabetes, cancer, because of the disruption. So the hypothesis is because the services are disrupted, and you don't have access to your screening, your medications, renal dialysis, your heart meds, etc. And so you start to see that we need to unpack a little bit more and understand better so that people are better prepared before an event. And that's one of the priorities that we've identified in our research agenda, to really quantify that vulnerability some more, understand what causes it, and then use it to reduce this adverse effect of excess mortality, especially in people with NCDs following extreme disasters. So the impact continues for a long time. Take Tropical Storm Melissa, which you've been talking about. The year before, folks in West Jamaica had another record-breaking hurricane, Beryl. Beryl gave a terrific blow to parts of Jamaica that just 1 year later got another hurricane. So it's unprecedented that you can't able to recover. The last point to make, many people with NCDs have a pre-existing disability with sight, with ability to walk, move around if they have an amputation, and so on. And I think it's a good practice. I've seen this in a couple of places, including in Tobago here, where folks with a severe disability are pre-identified either in the community center or the health center. There's a confidential register between the health authority and the disaster management agency that in the event of, then they know in advance who needs Medivac, who needs insulin, who's got, and so on and so forth. So I think that's a sort of good practice that helps to mitigate against the exposure I see, especially for people with NCDs. There are others, impacts on food supply, impacts on water, but I'll focus on that is which is causing excess deaths. That should be preventable if we understand it better and act on it.
Completely agreed.
So let's turn back to the young folks, and often portrayed as victims. You see children, young people in videos and so on. But they are also leaders. They are responders. They'll often be the first to help in a household or in a community. So can you say something, any stories of resilience that you have seen, or innovation or community action that you've seen from young people after Melissa?
Of course. In fact, that was the most touching part of doing all of these interviews, where we're going into communities and spaces where there's widespread devastation, but the Jamaican spirit, I feel, is very resilient. And I'd say the Caribbean spirit is to be very resilient. And so in every single place that we went to, young people said, yes, this is a hard time, but I'm doing X, Y, Z. And some examples of those, examples of resilience, innovation, etc., would be there were so many schools where the sixth formers were coming together to cook hot meals for affected families, or they're joining different associations to help clear roads in St. Elizabeth, Westmoreland. Or one school also started a match that or top that. So they were raising money at their school and then daring other schools to also kind of match that or do even more. You had many student council presidents as well taking on their own initiative to try and identify students who had not returned to school as yet, or who, maybe they haven't heard from in a while. So, some of them have just said it plainly, we need to include youth before the disaster and not just after, because young people were a core part of this recovery effort. They were the ones who are out there helping to clear roads, helping to deliver, groceries and other things needed to those who were most affected. And so I think it's an area that we need to look at ourselves and say, okay, young people are not just a part of the response to something that happens afterwards. How can we co-create some of these policies that are needed to guide what happens when a disaster is happening? For example, you also look at, school climate policies that probably need to be updated and reflect the different types of disasters that we can have, as you said earlier. You mentioned Guyana and the forest fires. Flooding being another big, issue that also affects Caribbean countries, and this happens quite regularly during, or wet season or hurricane season as well. So I think the message is very clear. Young people are already creators, innovators who have lots of ideas and also have the exuberant energy to be a part of our recovery efforts, but let's also have them as a part of our planning efforts. And with that, I'll also hand over to you for your closing message, Dr. Hospitalis. And I'd say if you could leave us with one action that would make the biggest difference for health before the next disaster, what would it be?
Well, given where we are and what we face and the threat of extreme weather and climate to people's health, I would argue for health to really be put front and central in the planning for response recovery. And it begins long before, which has been said. It's all of the stuff we're doing normally that puts us in a position to be resilient in the face of extreme weather or not. And we are a resilient region and set of nations. Putting health at the center of this, I think, is important. Getting our heads to declare that. Our heads of government, they talk about climate change, but they've not yet said, climate resilient health systems and people should be at the center of our thinking and responding to this climate disaster. And I think that's something I would call for as I conclude.
Great. I think that we're kind of wrapping up our conversation. I think we've touched so many important points throughout, especially being able to just highlight that, hurricanes are more than just a one-off structural or infrastructure, roads being damaged, roofs lifting off. They're also looking at how this has a long-term impact, and can also impact those who are living with lots of different comorbidities that get even more complicated in the aftermath of a hurricane. And we've also, of course, looked at how our young people are a part of this solution. We've looked at the mental health impact on young people, and how they are also stepping up and being leaders in their different communities. So I've really enjoyed the conversation, Dr. Hospitalis, and I think it's a great way to kickstart this entire webinar. Many thanks again to the Healthy Caribbean Coalition.
Perhaps just the last note as I'm thinking about it, and it can be framed up also, given that the whole population is affected, who cares for the carers and our health staff and other emergency responding staff that are in the front line of things, oftentimes continuing to work and serve, and their own family and their own household has been badly impacted. And addressing that should be part of the recovery response mechanism. We have a lot of that in the Caribbean when others come in from nearby and from your neighbors to help. And that's part of being resilient, especially where we have such very small states working together, helping each other.
Right, completely agreed on that one.
Danielle, are you?
James, you can go straight into the rapid fire, and I see that your guests are already lined up. Go right ahead.
Hang on a sec here. Just bear with me. I'm having some challenge. I had to reboot this morning.
All right, so I see your guest, James. So perhaps maybe I can assist in getting started by reintroducing our panelists. Vanessa Nurse, the nutrition officer of UNICEF Jamaica. Rochelle Hunt, I don't see Vanessa here, but Rochelle Hunt, the health focal point governing body of the Barbados Red Cross Association. So right here in overcast but hot BIM. And Miss Leah Maria Richards, the chief sub-regional program for the Caribbean. You're also here in Barbados, aren't you? So you can identify with this weather. And Mandela Christian, who's the program manager, Preparedness Response to DEMA. Where are you located, Mandela? You're here as well?
Yes, that's correct. I'm currently based in Barbados.
Currently based in Barbados. All right, so we have a almost full Bajan team, James. Are you ready as yet?
I'm not
Yeah, I
Bajan, but
think
I'm based
so.
there.
Okay. Sorry about that.
That's all right.
Glitches on my side. Thanks for pinch hitting there, Ken. And I guess I'll start with the Barbados Red Cross and how you and others, but definitely I think of Red Cross going back all these years now as a superhero in the disaster and emergency response at on the community level. And how do you see it from your point of view? What do you experience? What are some of the things, the lessons learned? What are some of the stories of resilience?
Okay, thank you for having me. It's a pleasure to be on the panel. Now, if Barbados Red Cross was a disaster response superhero, our superpower would be building resilient communities by turning ordinary people into extraordinary people, responders. Our work begins long before a hurricane or a disaster occurs through community disaster response teams, first aid training, psychosocial support, shelter management, and preparedness education. We equip communities with knowledge and skills to protect themselves and their neighbors. Because our volunteers live in the communities they serve, they are often the first to identify those who need help the most. But resilience isn't built only through emergency training programs, like also it's built between our Meals on Wheels service support, where we go out to older adults and vulnerable persons throughout the year, providing nutritious meals, regular welfare checks, and social connections. For many individuals living with non-communicable diseases, these relationships become even more important during disasters, when access to medication, healthy food, electricity for medical equipment, and routine healthcare might become disrupted. One of our greatest lessons learned is that preparedness must be people-centered. A hurricane may last only a few hours, but chronic diseases don't pause for disasters. Knowing who the vulnerable members of our communities are before an emergency, strengthening local volunteer networks, and working closely with government and community partners allow us to respond faster and protect health and support recovery more effectively. Our greatest superpower isn't our Red Cross emblem, it's our volunteers, it's our partnerships, and our communities. When we invest in preparedness, nutrition, health, and community resilience before a disaster strikes, we ensure that no one is left behind, especially the ones who need us most. Thank you.
Thank you very much. And would you offer one key lesson learned that reminds us of why community action matters? You had a very good answer earlier.
One of our lessons learned is, I think, with Hurricane Beryl, if you all remember the fishing community, one of the, like 90% of the fishing community was affected. And for us, we learned that community action can restore and rebuild function very quickly, where we went into the communities and taught some of the fishermen who had lost their fishing boats to make fishing pots. So it was another option in terms of rebuilding before we even look into the infrastructure and try to get the actual boats rebuilt. The fishing pots can still bring income and sustain the community during the disaster. So we usually try to push for community resilience with the materials that you have, even with simple actions. So community resilience allows you to bounce back as fast as you can with the simplest things, materials.
Thank you very much for that,
Hey,
sharing
if I
that
could
key
just jump
lesson.
in here. Rochelle, I just wanted to really challenge you on this. Have you kind of curated this? Is there a script that can be followed in the future? Because this sounds like a really innovative community, response.
So we have at least 8 community disaster response teams within that were created within the communities of Barbados, and we have trainings that we usually go into the community and train them in different aspects of, would it be emergency, first aid, search and rescue, nutrition, psychosocial support. We have CDRT teams in Bath, Orange Hill, Hillaby, Whitehall, Charles Royal Bridge. So we do have scripts, we have PowerPoints, we have trainers, and we usually go out, we look for the vulnerable communities that we identify. We meet with the community. They are the forefront in what is done in the training. They would identify the vulnerabilities in the communities, etc. And we train them in how to respond in the event of a disaster.
Thank you. And then I guess I'll turn to PAHO, Pan American Health, our long-standing international partner in health. And along the same lines, ask you about, how is PAHO responding on the ground? I used to be part of the disaster response team many years ago. How is it working now? What are some of the key lessons you see as we face more and more disasters?
Thanks very much, James, and good morning again to all the colleagues. This part of the webinar is, for me, the most exciting because we get to talk about the realities on the ground. So for PAHO, many of you know that we really put our focus in terms of our technical cooperation at the level of the ministries of health in their remit of governance of the health sector and in terms of the preparation and plans that they need to have established. It's important for me to just come back to a point that I made in my opening remarks about climate resilient health systems. And I think it's important for us to understand what that means. And I just wanted to take a couple of minutes to unpack that and in terms of the lessons learned. So it was mentioned by some persons in terms of the service delivery model that we need to consider service delivery models that are more agile, especially as we prepare for a hurricane, a storm, or some eventuality that disrupts the health sector. And these service delivery models, very much linked to what Rochelle just mentioned, is most times at the community level and depends very much on the civil society partners, because many times health workers themselves are trapped or dealing with their own personal emergencies. Their own homes have been affected, their family members have been affected. And so to what extent are we putting in place service delivery models that are agile enough to be able to respond to the needs of persons with NCDs? I think that it's important for us to look back at having an established list of persons, and this is not only health workers, but people who are trained in advance of emergencies such as hurricanes, etc., so that we know that there's a roster of health professionals or service delivery persons who will be available to attend to persons with NCDs. Related to service delivery models, we also need to talk about the infrastructure of health facilities. And James, you too mentioned that in terms of smart hospitals. But I think that smart hospitals, in terms of an investment, is one that not all Caribbean countries have adopted. And I think that this is the time that we really need to showcase examples like the smart hospitals in Jamaica that withstood Hurricane Melissa. So I know my time is up, but there are many more other service delivery models that we need to consider, and I'm hoping that we'll have time to discuss this throughout the webinar. Over. Thanks.
Thanks a lot for that from the power perspective. Sedima, every superhero needs a team coordinator. How does Sedima work at bringing the different sectors and partners together in which health is embedded to try to protect people's lives and health? And what's one lesson about building a stronger all of society response that you could share?
So thanks very much for that question. And yes, it is our mandate at Sedima. We are an intergovernmental agency of CARICOM with responsibility for implementing comprehensive disaster management across the region, which is a holistic approach towards disaster management. So as you know, during disaster periods, a number of partners, governments, entities, even pop-up organizations want to support the impacted state. But that in itself, if it's not coordinated, can be a secondary hazard to the state if all of these partners descend on the country during this time of need. So what we have is the regional response mechanism, which is an evolving system through which all partners with interest in disaster management are encouraged to work within this mechanism to provide support to the impacted state. Under this mechanism, we have four key structures. There's a governance structure that looks at all the legislation, the partnership agreements that we have, the MOU agreements, and so forth that guide and dictate how we operate among ourselves. We have a sub-regional structure, how we have subdivided the region to provide targeted support to all the states, given the wide geographic area that we cover. We have a number of regional response units or SID support teams that we could pull on to provide support to the states, and we pull on support from the non-impacted states and from all partner organizations. And all of this has to be coordinated, and it is coordinated for the Caribbean Development Partners Group that is co-chaired by the Sedima Executive Director and the UN resident coordinators operating in the region. And all the key organizations, they form part of this body. We have further subdivided this group into 10 thematic working group areas, or these are essentially emergency support functions that align to their mandates. So there are clear entry points for the partners. And of course, one is focused on health, inclusive of mental health. There's one on WASH, water, sanitation, and hygiene. We have one on protection that looks at protection against sexual exploitation and gender-based violence, and a couple others. So what this does, given that there are clear areas where partners can provide support, there's a clear mechanism. It also facilitates coordination and exchange of information among the partners so that our efforts are complementary, meaning that the work of one partner will not undermine the work of another, rather it should uplift the other. One lesson I should say, just to answer the last part of your question, I don't run out of time, learned in recent times from both Beryl and Melissa, is that the structure, it works, especially in light of what we saw happening with the shifts in geopolitical shifts in foreign aid policy over the past 2 years. Resources are very much limited. So this arrangement has forced us to come together and work together collectively from a same common hymn sheet and provide targeted support to impacted states. And we have seen significant basically gains, and we have avoided basically wastage or duplication of efforts and optimize the limited resources that's available to us.
Thanks for that, Mandela. You know, I've often thought that the Caribbean has a talent, a good practice that we don't perhaps even sufficiently realize, and it's this whole area of disaster response, and the coordination piece is so important, as you point out.
All right.
So, quick round of questions to wind up this section in one sentence. What's the single most thing the Caribbean should do now to better protect its most vulnerable people before the next season? Well, the next season is upon us. We're here. And we'll start with the Red Cross. Rochelle? One thing we could do.
Prepare, prepare, prepare.
Okay,
So
that was
once we prepare the community to expect, don't just wait till the warnings are out there. You should be preparing from January before the hurricane season. Once we train up our communities to prepare, if a disaster strikes there, they will be resilient. They will bounce back.
And yourself, Leah?
So for me, I will just continue what Rochelle started. And in terms of preparedness, we have a number of tools to help persons living with NCDs to know what are the checklists that they themselves should have, things ready, medicines, putting all their documents in order, their health records, etc. So those tools, we will put it in the chat for the webinar, but they exist. What we need to do is go into the communities and sensitize persons at the level of the household so that they don't wait for the health sector to come to them, but they themselves can take care of their own health situation. Thanks.
For that, and Mandela, back on to you.
Yes, I will add to that. I would say preparedness definitely, but multi-hazard preparedness. What we see happening during these events, yes, you may have a hurricane, but that leads to landslides, to floods, and then even that can lead to vector-borne diseases and other complications stemming from one event. So don't just prepare for the hurricanes, but anticipate what else could happen and take that into consideration. And we really need to establish clear data-driven baselines. So information is key of who our most vulnerable populations are, where they live, the conditions they manage, and the support they need, because we cannot protect people if we don't know what the issues are. So only if we have good, robust baseline, we have a good mapping of our vulnerable population, then we could tailor our response and target or tailor our response to meet their needs.
Mandela. So that we've been in this rapid fire question section, and we're gonna wind this bit up and transition.
It certainly has been rapid fire. I mean, the one thing I took away from this is not only that the panelists, I'm not sure how you did it, but I felt the adrenaline. But you know what? The other thing I took away is so climate resilient health systems, James, it's probably more about the people and communities and less about the infrastructure, which is
Well, it's
different.
both. It's both.
We often speak about infrastructure and we concentrate a lot on it, and it's important, but we neglect the communities and the individuals that need to be more resilient. And that certainly came out in that conversation. Thanks for that. Janae, I see your camera's on, so I guess I'm handing the baton over to you. Thanks, James, for an exciting roundtable.
Pleasure.
Thank you, and good morning, everyone. I will be leading a bit of a reflection activity today, and I'd like, oh, can you see my screen on Mentimeter? Oh, one sec. Okay, here we go. I would like everyone to.
Still not seeing us yet. Do you have to click something?
Okay. I'm trying to pull the right screen up. Okay, can we see now?
Perfect.
Okay, great. Thank you so much. Yes, so before we begin our reflection activity, I'd like everyone to open Mentimeter on your phone or computer. You can join by scanning the QR code on the screen or by going to menti.com and entering the code 84329779. And I see a few people trickling in already. So throughout the discussions this morning, we've heard a lot about damaged health facilities, disrupted food systems, interrupted treatments, and the lasting mental health impacts of disasters. We've heard about how disasters affect health, from injury to access to medicines and healthcare services to food security. But at the heart of every disaster is a person, a family, a community trying to navigate uncertainty. And I'd like us to take a moment to reflect on the people behind these discussions. So think about someone in a community living with an NCD. It could be an older relative managing hypertension, a young person living with diabetes, a friend managing anxiety or depression. Imagine a hurricane warning is issued tonight. What is the first challenge they might face? What support would they need in the first 24 hours? What support would they need in the weeks that follow? So if you have already joined Mentimeter, I would like you to now respond to our reflection question in one word or short phrase. What is the most important thing needed to better protect people living with NCDs during disasters? I give a few moments for everyone to respond. So thank you already for sharing your responses, and I can see we have a few themes already beginning to emerge. We have education, information, preparedness, collaboration, access to medicine, continue access to care, adequate resources, well-coordinated systems, an action plan, community resilience. What stands out to me is that there's no single organization or ministry or sector that can deliver all of these on its own. And protecting people with NCDs during disasters requires, as we can see here, coordinated action across health systems, disaster management agencies, civil society organizations, communities, development partners, and individuals themselves. And each of these responses, to me, represents an opportunity for action before the next disaster occurs. The reflections that we're sharing and continue to share. Thank you so much for everyone for sharing your perspectives. It highlights to me an important reality that disasters don't only create vulnerability, they expose and amplify vulnerabilities that already exist. And as we move into the next session, we'll hear from experts, advocates, and people with lived experience about practical actions that can be taken to ensure that people living with NCDs are better protected during and after and before disasters. So this is my brief reflection activity with all of you, and thank you very much for your reflections. I see a lot still coming in, and we'll take notes of this as we continue to have these conversations. So I'll now hand back over to Dr. Connell as we move into the
Sure,
next
thanks,
segment
Janae.
of
So, I
today's
mean, before you
program.
change your screen, I am
Sure,
seeing
yeah,
there's some interesting responses. It seems like people definitely understand the need for preparedness, but more importantly,
absolutely.
a plan, a support plan, and perhaps HCC could have this discussion. What does that plan look like? We've already decided that it's not just an infrastructural problem, but a community-based problem. And is there a community plan, a community-based plan, for instance, for people living with NCDs or including mental health disorders? Okay, I'm going to shut up now and hand the baton over to Maisha. Maisha, thanks for taking over the session. I'm really excited to hear this panel discussion. So I'm going to turn my camera off now. Over to you, Maisha.
Thanks, Kenneth, and thanks, Janae, for that session. I'm really excited to hear from the panelists we have right now, building on the experiences and the kind of responses we just heard from Sedema and from PAHO and from the Red Cross Society. So we have three panelists for the session. We have Dr. Suzanne Soares-Winter. She's a clinical nutritionist at CARE. We have David Johnson, Dr. David Johnson, who's the founder and president of Let's Unpack It. And we also have Debbie Chen. I'm not sure if Debbie's coming on. I'll keep an eye. If she does come on, she is the executive director of the Heart Foundation of Jamaica, and she's also the vice president of the Healthy Caribbean Coalition. And so we're going to start with Suzanne and talking about centering nutrition during these disasters. So Suzanne, what policies and preparedness measures should governments prioritize now to ensure healthier food environments in disasters? And you, having being based in Jamaica, have had to experience this, and you were very close to the ground in the response and the nutrition response post Hurricane Melissa. So over to you.
All right, thank you. And I hope you're still hearing me clearly. And,
Yes.
Thank you always to HCC for bringing these conversations to the forefront, especially now that we're in another hurricane season. So generally, from a nutrition standpoint, our responses, we really need to ensure that disaster survivors receive adequate, safe, and appropriate nutrition. And the aim is really to save lives, accelerate recovery efforts, and build resilience for future events, because that's very key in our setting. And just a reflection so far show that disasters do have varying degrees of disruptions and impacts on nutrition. And so the responses must take into consideration the vast array of impacts. So anywhere from climate and environmental protection policies, food commodities and distribution access mechanisms, because we know, especially in the immediate aftermath, that's when food retail and distribution are completely disrupted. And we also need to consider things like wastewater management, hygiene, and sanitation. However, given that high prevalence of NCDs and coexisting malnutrition that we still have affecting us, and these people have heightened risks, and this is where I like the donation guidelines that HCC is putting forward, because it has built-in mechanisms that enhance and promote those healthy options. And, it's very crucial for emergency donation supplies, because we realize, Hurricane Melissa did show us that there was a wide array of donations that didn't necessarily, they lean towards that default position of unhealthy products. So key policies to engage, I can't stress the importance of potable water, because maintaining hydration is probably the most crucial survival mechanism. So water probably needs to be the most crucial and first item in a donation basket. Social welfare and supplemental nutrition assistance programs, these provide existing frameworks for protecting marginalized groups. I can't speak enough on regulations and standards for food labeling, food safety and quality, and just strict adherence to these, especially during a hurricane, because it secures the nutritional quality of products that are imported, and also protects even trade aspects, because that's a time when, you're at risk of a lot of illegal imports and low quality, potentially unsafe products. I know I have to go quickly. So school nutrition policies in emergencies, they help to provide and support and combat pediatric risks. It's a familiar framework. It also encourages re-enrollment, especially important after schools. And finally, just, maintaining public education and literacy, because these must remain consistent before, during, and after the emergencies. Breastfeeding, sanitation, simple hand washing, those policies must remain at the forefront with our policies. And I think my time is up, or do I have a few seconds more? so yes. So I think I'll stop there and hand over to the next panelist.
Thanks, Suzanne. So we're going to shift to mental health now, and I've seen a lot of this in the chat, people raising this idea around mental health. And I was reflecting as I looked at this, the kind of questions, and you, David, is at the recent high-level meeting of NCDs, and Kenneth, you may recall the Honorable Prime Minister Davis of the Bahamas talked about the kind of collective anxiety that the Bahamians experienced at the, as each hurricane season approached, really just seized by this anxiety. So, mental health prior to, during, and post. So the question for you, David, is disasters have lasting impacts on mental health, and we've talked about that. Many countries with support from PAHO are revisiting mental health systems. What is the systemic change that needs to be addressed to support mental health and well-being before, during, and after disaster?
Thanks for the question, Maisha. I'm really happy to be here with you. I think for me, the systematic change that needs to happen really is that mental health and psychosocial support need to be integrated into every level of disaster risk reduction and management. And that runs the full gamut of before, during, and after the disaster. I think we are all aware that people already living with mental illness are particularly vulnerable to the impacts of disasters. But I think more generally, that everyone who's affected by a disaster will likely experience some form of psychological distress. And while, yes, for many, this will ease with time, there are some people who may experience effects that persist into even more serious mental health challenges. I mean, from a context specific point of view in the Caribbean, this is particularly complicated by the fact that we have a rolling hurricane season effectively, every year, same time of the year, where we're looking at preparing for hurricanes, but we're also preparing for a myriad number of other hazards. So with respect to hurricanes, though, I think it's quite topical that the recovery is forced into a 12-month window. So you're hit with a hurricane, not much time to recover before the next hurricane season, not to mention in the particularly active years that you're constantly in a state of alarm and readiness. And that is not necessarily matched with the fact that poor mental health outcomes do not follow a hurricane calendar. And so for young people in particular, I think we ought to be concerned, particularly because the regional data is pointing to the fact that a lot of young people are struggling with their mental health, and 54% of them are reporting that they lack a reliable support system. So we know that disasters displace families, they interrupt routines, and all of these things, by the way, are protective factors for mental health and well-being. And so echoing the sentiments shared before, it's not that disasters create a whole bunch of vulnerabilities, but they actually amplify those that are already present. The other bit, of course, is that mental health services are not often regarded as essential services. And so the care that is usually interrupted for a protracted period of time, that's of a concern. And so what I would suggest then is that this deepens the call for a shift during the peacetime from the over-centralized, institutionalized care model towards to an integration into primary care, but also a stronger community-based model of mental health services. And why? When care is decentralized and closer to where people live, the communities are better positioned to restore those services and maintain life-saving mental health support after a disaster. And so mental health cannot be regarded as this optional add-on in terms of disaster response, but it must be explicitly treated as an essential service. That's running the full gamut again of continuity plans for medication, follow-up, referrals, etc. But I also want to touch here at the end on the fact that we need a trained mobile mental health response team. I know that PAHO and CAPSIC are leading up work on this, and I would hope that it expands. But I also think that it needs to reach beyond just the specialists. Or first responders, shelter managers, primary healthcare providers must be trained in things like the MHGAP Humanitarian Intervention Guide to recognize and manage mental health needs in emergencies. But I also think we need to be doing more to manage the mental health and well-being of our first responders. They see things no one should ever see. They hear things no one should ever have to hear. And so it's really important that we're treating that as well. And so I'll wrap on the point that the goal must not simply be to deploy a psychologist after a disaster strikes, but the collective goal must be to build a more robust and community-based, resilient mental health system before a disaster ever strikes.
Thanks, David. Excellent. And now shifting to Debbie. Debbie is the executive director, as I said, of the Heart Foundation of Jamaica. So like Suzanne has, just come off the experience and still experiencing the after effects of Hurricane Melissa. And so Debbie, we're talking to you about the role, we want to hear from you about the role of partners, the critical role that partners from various backgrounds can add to the response. The Heart Foundation was central to the community response and part of the team that responded before, during, and after the disaster. Based on these experiences, what recommendations would you make to governments, health systems, donors, development partners to better protect people, particularly those living with NCDs, before, during, and after disasters?
Thanks, Maisha. Hi to everyone. It's important for us to remember the various phases of these disasters, which we had Melissa, but it could be an earthquake or other things. And to be quite honest, in the initial stage, NCD is the last thing in front of your mind. meaning that you have to be, you're surviving, literally. Are you drowning? You know, are there landslides? You have no utilities. So even though that's our focus, we have to realize that in the first instance, that's not the priority for anybody. But we have to be prepared and plan, have plans in place so that once that initial phase passes and hopefully has been sorted out, the systems are there ready to deal with the NCDs at that point. Initially, healthcare is going to focus on trauma, drownings, things like that, and basic food, unhealthy or not. But the preparedness will enable us to be as prepared as the unhealthy food industry are. They're already, you know. And at the first opportunity, there comes the SSBs, there comes the processed snacks. And people are starving in these situations. So they will take it, and us as the health professionals can't even really say anything at that point because of the nature of the situation. So it has to do with preparedness. I mean, the other things are just obvious, and they're in most plans in our region to protect our health facilities. Do we have solar? Do we have an independent water supply? Of course, this may be blown away, but other than that, do we have an independent water supply? Is our medical records cloud-based? So the scenario here was in St. Elizabeth in particular, and other Western parishes, they lost their prescription, they lost their medication, they lost their ID. So they're standing there, they're hypertensive, they're diabetic, and they have absolutely nothing left except the clothes they are standing in. How does one begin to deal with a scenario like that, even if a mobile, say, pharmacy were to come along, even if their health center is still standing, which in some cases it wasn't? So these are the realities. But if we had something cloud-based, and I'm sure we do in some jurisdictions, then people from external can come in and start, you know, looking up the records. Yes, they might have to accept that I say I'm Deborah Chen and I may not be Deborah Chen, but at least we can start somewhere. And then in terms of the register of persons with NCDs at the local level, the community are critical. It has to be the people who walk the ground, who know. You know, we went up lanes and there were a man in a wheelchair with no roof, no food, nothing. Everything is gone, and he couldn't move. He couldn't come out of his what was left. But it's only the community workers who are going to be able to walk up and down these areas. What we saw was, let us take the town of Black River, which I have some connection to. The food was there being given out in trucks in the town, but nobody was going down into the lanes. These people who could not walk, they had a stroke, whatever, they were kind of sidelined. So, I mean, people like you know, who were more conscious of it would go and give out into those places, because all the able-bodied people were pushing and shoving and getting all the food and the water, and the other people who were shut-ins and didn't have family. So, you know, especially if us as NGOs can find some way to assist and not to necessarily go to these central areas. Also, in the plan to mobilize healthcare workers who are not necessarily in the areas affected. Now, we have no idea where a disaster is going to strike. In some of our islands present here in the HCC, a disaster is the whole island because of the size of it. Some are bigger, like Jamaica, that you have people on standby. We don't know when this is going to happen, and if it's an earthquake, it's even less predictable. But can people in the east go to the west, which is what happened eventually, where health workers were redeployed, bearing in mind that these healthcare workers are part of the disaster. They don't have any roof, they don't have any water, they can't find their family members, and so on. So we have to be mindful of that. In terms of the prescription items, again, policies, and I'm sure we have them, about where do you store these supplies, and not because you can't, okay, so it goes to the capital, but the capital gets blown away or is in the earthquake. What about somewhere else? So I'm sure that's in place in a lot, already in many places. Where are the supplies located? Not just food and water, but the medications in particular. A policy to allow to relax, and this happened in Jamaica with the National Health Fund, relax the requirements that you could only get, say, 1 month supply. So where we have a program here where we have a card and you get, so we need to relax that. If you have a prescription and you found it and it says 1 month, well, you're just gonna have to extend it because not everybody can get to places. So I think the prescription is also important. I think it was mentioned already about the unhealthy food, and the HCC has an excellent publication about that. The private sector are very prepared. They're ready to go with all their branding, all their t-shirts, all their packages. So we need to find a way to just be as equally prepared. So I think, you mentioned mental health, that's good. And of course, public education, but preparedness is the key.
Thanks, Debbie. Thanks. Suzanne, and thanks, David. Excellent responses. We're going to go to Q&A, but before we do that, I wanted to highlight a resource that HCC developed in partnership with a number of key partners, including Earth Medic, Earth Nurse. And I'm going to share my screen really quickly, and I'll ask the team just to drop the link into the chat for this. So these are NCD brochures, and they're brochures for people living with NCDs during natural disaster-prone areas. They were developed with PAHO, the Caribbean Public Health Agency, CARFA, Earth Medic, Earth Nurse, and the Eastern Caribbean Health Outcomes Research Network, or ECHORN, originally developed by Dr. Saria Hassan. And there are a number of these: asthma, children with asthma, adults with asthma, type 1 diabetes, type 2 diabetes, hypertension, anxiety and depression, natural disasters or cancer. Also, a guidance for civil society organizations, reflecting on some of the points that Debbie has just shared. And this is a closer look at what the resource looks like. And some cross-cutting themes throughout all of the brochures are mental health and healthy diets. So have a look at those and use those resources and deploy them in your communities. So let's shift to Q&A. I'm going to invite all of the panelists, everyone who has been who's participated thus far, to turn your cameras on. So that's James, Mandela, Leah, everyone, and we'll open up to Q&A. We've got quite a few questions in the Q&A chat box. Kenneth, you as well. You can co-lead here with me and jump in. And also, if anyone has any reflections on anything they've heard other panelists say, burning points they'd like to share, please feel free to jump in. I'm going to start with the first question that we have in the Q&A, and it's from Al Lestrade. And it's basically saying, what is preventing the region from deploying these capabilities before the next disaster, rather than once again trying to assemble them during the crisis? And I think this is, the general theme of how are we learning lessons from the past and ensuring that we are being proactive rather than responsive. And I think this is quite a complex question, because a lot of this is about resources, right? In addition, I think we all know we need to plan in advance. So who wants to jump in and take that question? We heard from Leah at PAHO. I don't know if PAHO's still on. And we know Sedima and Red Cross are doing a lot of work. So this, to an extent, has been responded. But does anyone else want to jump in about anything that we can do to be more proactive? I don't know, Debbie, jumping back to you, is any lessons you've learned at the Heart Foundation that you were doing kind of proactively as moving forward? Any changes that you've made?
Not really any changes. Our head office was out of the main disaster zone, so we were still able to function. As regards the office itself, we have to make sure things like we have a generator, which right now was broke down. We're trying to get a new one. But how do we even keep functioning at the head office to be able to go out with the mobile teams once so things like batteries, to operate the various machines, the backups to things like, one of the problems is we're too tech driven these days. So then your credit card machine doesn't work and your NHF card doesn't work, and things like this. So, a generator is really critical in those parts, and just us being prepared as well to go out. If we are not affected at central office, if we're affected centrally in our situation, we really would be hamstrung as to how to move forward. But again, it's just preparedness.
Right. Anyone else want to jump in on that? If not, I'm going to jump to this question around NCDs and pre-existing disabilities from Leah Schaffner. She asks, in addition to separate registers to identify extra support needs of people with disabilities, are there examples of integrating disability accessibility in emergency preparedness and response? For example, in training of local responders. Any examples? Okay. Maybe that's something we can wait. And if anyone who's actually attending the webinar, if you've got local examples, please feel free to drop those into the chat. Marcia, is that a panelist? Marcia Thomas Yetman? I think that's an actual attendee. I'm not sure if we can get audio from a participant. Maybe just write your answer in the chat. Mandela, over to you.
Yes, sorry, I was just trying to find the raise hand button. Yes, so we do our best to be inclusive in whenever we respond. So when we do training of our regional response units or the regional response teams, we take that into consideration. How do we factor in, considerations for the differently abled persons, for sexual abuse and gender-based violence and so forth. So we work with various partners such as UNICEF, even CARPHA, PAHO, in putting together the training material, in delivering the training material to ensure that these considerations are flagged and that the training reflects that. So the persons we send out, they know different signs and different things to look out for when providing support, that safe support to the impacted population. And also that we have working on establishing clear referral pathways. So if we see any situation that is beyond our capacity to deal with on the spot, then we could quickly refer that to the local authorities so that it can be aptly dealt with in a timely manner.
Thanks, Mandela. And Kenneth, I see your hand is raised.
Great. I was trying to find my virtual hand as well and to maybe make it more ethnically aligned, but I can't change the color. So Suzanne and Debbie, so here's the thing, right? There is an elephant in the room. I know you know where I'm going with this, an unhealthy elephant. After disaster, we're all concerned about survival. And so there's the risk that a lot of donations that we receive are not the healthiest, but they allow people to survive. We do run the risk, right? It's a balancing act. How do you get people to understand that, okay, legitimately under these circumstances, we have to kind of be a bit more relaxed. But this should not be the norm moving forward for patients living with NCDs. We can't look as if we're unrealistic, right? By saying, listen, you can't have anything canned when there's no refrigeration, or you shouldn't have this because that's all you have to survive. So how do you balance that? Do we have a responsibility perhaps in guiding regional administrations to this delicate balancing act? Because, of course, as Debbie suggested, I know who is looking at this, and that is the commercial determinants of health. They're ready to jump in there by saying, listen, we helped you during the emergency. Continue eating like this post-emergency. Over.
I think the government plays a role because they do. I know in the immediate aftermath, and I mean there should be preparedness, but I know in the immediate aftermath they were contacting food manufacturers, which I happen to know something about, and they were asking them what supplies they had in their warehouse, because this was not a disaster, and we didn't know what was going to happen. And so they were asking around and trying to get donations, but also just trying to find for food security. So they could play a role in terms of what they access, because some things are less harmful than others. Because
Correct.
what we don't want is this bomb, which we got some of, where you have the diabetics going haywire with no medication, the hypertensive doing the same thing, just standing up in their clothes with no medicine, and then they're given Pepsi and Coke and chips and all of that. So even that is the thing, that you have this time bomb. They do that for a week or two, and then they eventually get to healthcare, and by that time now they're really in trouble, and their whole health profile
Absolutely.
will take a lot to fix. So it's a challenge, but the government could start by trying to focus where they can on getting. Now you have the companies who do their thing as well, but you do have a government coordinating mechanism that does go to all the manufacturers and distributors, and they do amass stuff as well.
Excellent. I see some other hands up.
If I can just add to that, so I mean, the reality is we are reliant on food industry and food suppliers to provide food and have it distributed, and they have existing supplies for distribution already in place. I think one of the biggest challenges that we have in public health, and we're slowly getting there, but it has been such a long and arduous process, is just having healthy food policies in place. So a basic thing like our food labeling standard is going to help to guide what foods can be supplied. It can protect what comes into our ports, because emergencies are a time when things go haywire. Even the best systems will go haywire. But if you have in place structured regulations like a food labeling policy, technical regulations that guide what the quality of foods that should even exist in our setting, controls what comes in, controls what you can provide in a donation response. Many companies, individuals from overseas, the Caribbean diaspora, were providing things, and how do you guide them? But you have to guide them through those examples. I mean, I always say to the HCC donation guidelines helps just as a structure to say, this is what you need to do. And yes, you have to be flexible because the reality is we don't have a lot of healthy foods available, especially in our prepackaged food industry.
Yeah.
So
Yeah.
getting that change, and how do you get it out? But you need those structured guidelines. And yes, things like a school nutrition policy will help to protect our children, get schools back in order. Schools are already structured with kitchens and so on. They're known in the community. So utilizing those existing frameworks is also necessary in our resource-strapped areas.
So if I'm hearing you correct, Suzanne, so change the options that are available on the menu so that even if you have to choose less healthy options, they're still acceptable, right?
Right, because we need to understand the culture, you know. So when we get a lot of donations from overseas, people may not culturally like it, and we need to recognize the variation in even our religion. You know, some religions don't eat certain things. So it's to make sure that, yes, you may not be able to have such strict nutritional guidelines, but there needs to be a threshold at which this is not accepted.
Yeah.
So Kenneth, there's quite a few other hands raised, Leah and Mandela and James. And just one point before you jump in, Leah, just to say that this issue around food has come up repeatedly in the questions. And I think for me, Suzanne, one of the most important points that you made that came through is the background policy environment that exists before and after and during, and which gets people, the population, accustomed to this idea that there is quality control in the food. So when the disaster comes up, you're not suddenly saying, hey, you can't eat this, you can't eat this. So over to you, Leah, and then James and Mandela. I'm not sure of the order, guys.
No, thanks very much. And I wanted to extend this conversation with regard to the donation of food to the donation of medicines. This is something that we also need to recognize in terms of the management of NCDs, that we do have persons who in good faith want to support the response to any emergency. And sometimes they show up at the airport, or they show up with a suitcase full of medicines because they had access to it in whichever country that they came from. And so going back to the point of what is needed, what we need are the guidelines. What we need are policies established in advance of an emergency that says this is how we manage the donation of medicines, for example. And then the other thing that I wanted to mention related again to donations and people acting in good faith is with regard to surge capacity. So many times we have the diaspora showing up at airports because they are nurses and doctors and they want to help. But many times without proper governance of that support, it becomes a little bit of pop-up clinics here and there, people providing services without knowledge and awareness of the Ministry of Health and other persons who are responding to the emergency. So just the donation and that fluid nature in terms of the response is something that we should have guidelines in advance for.
Definitely.
Thanks.
And it's usually in good faith, right, Leah? It's not, malicious in any way. These people are acting in good faith to help in the emergency. I think, James, your hand was up next.
I was thinking of the reflection that's come up a few times, that climate and what's going on is changing background things that are going on.
Absolutely.
And I wanted to bring us to the reality where food and ultra-processed access is concerned. It's not just disasters that are changing it. We have a disastrous situation already with the degree of penetration of commercial determinants and unhealthy food for children and for people with NCDs. And that's appalling. And so it's the sort of thing we should perhaps make some more noise about. The percentage of ultra-processed foods that constitute the calories of children and folks with NCDs, how much do we know about it? We know sufficient that, my point is the background in that regard, there's already a huge degree of penetration. Disaster just makes the slope maybe a little more steeper. But we have an unhealthy food environment every which way. Regulation, labeling, all the stuff HEC has been shouting about. Food reformulation and the resistance of industry, and there are various reasons for that. But I do want to point to that in making a remark.
Yeah, so the baseline environment or the background environment is really what needs to be changed and addressed urgently. And Mandela?
Yes, very good conversation and so much to unpack. So this is something that we have flagged. As you know, every time we have an an emergency. We conduct after-action reviews, and these things have been coming up since, well, in Beryl, definitely, in Melissa recently, and even before. So just to highlight a few things. So we have in the region a Relief and Logistics thematic working group that is co-chaired by SDEMA, Wolfwood Program, and there are a number of other partners on there. And that way we are able to get a better handle on the relief items going in. For non-food items, we have some standard list. And also for food items, we normally get that list from the countries. We get the national needs list from the countries. And we work with the various shipping companies. I don't want to really name a few, but we know them, the famous ones. And some of them are very keen that they do not take items that have not been approved by the countries. So if you come with it at the ports of entries, and that extends to even medicines as well, medical stuff, if it's not on the needs list that's approved by the government officials, they do not take it, and we do not facilitate it getting into the country. And that's where we're able to track the relief items from the suppliers all the way to entry into country. We also note that to speak on the number of pop-up entities that may come up with good intent. Most of them come with good intent, but some of them, yeah, they may have good intent, but their sources of funds and resources may not come from good
Best intent.
sources,
Yes.
out of the best intent. So we also have to do some vetting. So anybody coming through the regional response mechanism, especially the new entities, the pop-up entities, we have a process for vetting them, doing a background check through CARICOM impacts. And so they do some screening of these entities and let us know, okay, if this is a good partner we should be working with or not. And that goes all the way down to the country, and the country can take a decision and say, okay, yes, we're willing to partner with this entity, or no, they have some shady backgrounds, we're not working with them. And just to note that, like, entities like this World Central Kitchen, I know they were in Jamaica post Melissa, I believe they were in Grenada or St. Vincent as well. I can't recall, but when they do deploy, the menu that they serve or they cater to, it is informed, or I want to believe it is based on the recommendations by the states. The nutritionists, they would inform, okay, that is what our culture is. These are the types of foods we want you to bring in. And they cook based on the nutritional needs of the country. So it's not just a random, come in and cook whatever you want. As somebody mentioned, I can't remember who it was mentioned, there may be some cultural considerations such as religion. Certain persons don't eat certain type of foods because of their religion, and so forth. So you need to ensure that you're catering to all those needs. So a key lesson, just to wrap it up though, that we learned from, I would say, Melissa, is that we really need to bring a bit more coordination to that. And we have been working on establishing a nutrition, I don't call it the thematic working group, but like committee that is going to meet and discuss the nutritional aspects of the relief coming in. So it's not just bringing all the teen stuff and with high sodium and so forth, but to really look at the I guess the nutritional needs of the countries in consultation with the countries itself, and to plan the relief, the needs list or the foods list based on that, so that when we circulate that to the donors and to the partners, they are actually sending stuff that the country has approved and signed off on that is going to meet their health and nutritional needs. So just wanted to share that.
Thanks, Mandela. Kenneth, I'm going to jump to some questions in the Q&A.
Sure.
Two from David Howard, who is actually based in Barbados, and he runs cancer care services here. And he notes that he's very proud of the work that's being done, but he's wondering about mental health in particular and the stigma around accessing mental health services and how that's likely exacerbated during times of disaster. And another question he also adds, and I'd like you all to contemplate this question too, is around access to care for people living with cancer, and by extension, diabetes, and the range of NCDs during disasters. And, are there any examples of where physicians are deployed to patients that can't make it to centers? And he recalls the COVID experience where many of his clients either were unable to access care because they couldn't physically make it to the health centers. And there was also hesitation to go there. So one question definitely for you, David, and then perhaps others can jump in on that access piece.
Yeah, crucial question there. And I think stigma is one of those things that we're just going to constantly have to be working on in the background. I believe that during peacetime, we need to be doing more in terms of restructuring our mental health systems to address to this. I say all the time, and I know certainly the case in Barbados is that we do not have a resources issue. We have a public relations and communications issue as it relates to mental health. And so we need to be doing more to show people, what does care look like? What can you expect when you engage with a mental health professional? Mental health care is not just about taking medications. There's a full gamut of services that are available. But I think one of the things that we don't necessarily think of when we think of the packages that we create for response to disaster is the communications package. And so I think there's a role there to be played. And so I think where you've succeeded here, Maisha and team, with the creation of the brochures, we need more content like that. The content that's coming out on our radio waves as well needs to let people know where can they access mental health support, what can they expect when they get there, so that we're not leaving it for the masses to determine what the message is about mental health there. And so I know certainly that agencies like PAHO and others, and I'm sure CAPSIC is thinking of it as well, in terms of what does the communications package for mental health look like, not just from those entities that are providing the technical support, but as well for governments. What messages are they putting out in advance of a disaster striking that says to people what can they be doing to secure their mental health and well-being before, and what kind of access to care can they be looking at after the disaster? And so the work in terms of stigma reduction has to happen before disaster, but there's certainly a role as well during the response.
Maisha, you're
Sorry,
muted.
muted. Yeah.
I was saying thanks, David. I was thinking, Leah, back to PAHO a couple of years ago, the work they did post Maria and Irma around developing the psychological first aid kit. And there was one that was specially designed for young people.
Yeah.
And I think, we collectively have to continue to always kind of reflect on what resources have been developed already. What can we go back to? What can we use? Anyone want to, Mandela, I see your hand is raised, and then we can hopefully talk about the access to care for those living with NCDs who can't move to centers during times of disaster.
Mm-hmm.
So just briefly on mental health, that's also another important topic. We recognize in the past we did not focus too much on it because there wasn't really a visible effect that we saw, and it was really silent. Since we have established, I would say that was in 2024 or probably before, the CAPSIC, the Caribbean Association, so many acronyms, of psychosocial support institutions consortium, and we pool together a number of mental health and psychosocial support providers in the region to help standardize the support that is provided, as opposed to everybody providing care at their own standard. I know CANPA is a key player there, the UAD-RRC, University of West Indies Disaster Risk Reduction Center. Of course, CAFA and PAHO, they are key members on there, as well as a number of other entities. And they have been meeting to establish standards in terms of mental health care, how we provide that support during disaster periods. We have worked on a course, actually. There's a short course, virtual course that can be taken by all first responders, that has to be taken by all first responders prior to them going out into the field. It is available on the CDMA's Regional Training Center website, as well, I think, as the UNICEF has access to it in Campa. And the teams were deployed post-burial in both Grenada and St. Vincent, and in Jamaica post-Melissa, to provide mental health support. So it's still a work in progress. It's still a fairly new committee. They are currently in the process of fine-tuning and updating their protocols based on the lessons learned from Melissa, to streamline to integrate the lessons learned. But it is something that we are looking into, not just provision of care to the impacted population, but also the first responders as well, and also how we go about providing that long-term care, because it's not just a one-off thing. It's not just so you talk to somebody in the field. It's an ongoing process of ensuring that there are referral pathways. And on the wider health services, we are working with the Barbados Defense Force, they have the Field Medical Hospital. And I really think we need to mention this because this is a key asset we have in the region. It is currently certified at a level 1 and just about to get a level 2 certification. Correct me, Powell Kaffer. I'm not too sure if they already received the level 2 certification, but this is a huge achievement for the region. They were deployed in Jamaica post Melissa and provide some tremendous support in Jamaica when the health system was down, and we continue to work with them to provide support to streamline the deployment of that asset into any impacted state pending after an emergency. So I really just wanted to mention that. Over.
Thanks, Mandela. And Leah, over to you. And whoever wants to jump in on that important question about those living with NCDs and access. There was also a question around the elderly. Who's taking care of the elderly in these situations? So perhaps consolidate those responses. Leah?
Yes, I think so. My intervention is related to the continuity of care, particularly when health facilities are impacted. And so, as I mentioned in my earlier intervention, we have to look at different models, so different service delivery models, activate them when needed. I will give the example because I participated in the Health After Action Review in Jamaica post Melissa. And one thing that was mentioned was that largely at the community-based level, most of the county medical officers of health, I forget the exact name, but basically those officers who were responsible for catchment areas, they already had their lists. They had their list of persons with NCDs, the list of persons with disabilities, the list of cancer patients, the list of persons who they knew that they had to reach out to. They had phone numbers, contact information of their family members, etc. So this again goes back to the level of preparedness, not only within the health sector, but at the community level. And the fact that everyone had information in advance so they knew who to reach out to and who was most vulnerable. The other thing that I want to mention, however, is that the challenge remains with communication post an emergency. The immediate landing of a hurricane, the day after, many times communication systems are disrupted completely. And so this really affects our ability to touch base with persons who are extremely vulnerable. One thing that Jamaica learned is that, for instance, they had these Skynet satellite dishes, and they also had the emergency communications networks, but they were not positioned in a place that was close enough to the health sector, to the health facility, or where the health workers were congregating. So really, what my point is that when we talk about planning and preparedness, we really need to go down to the level of the most minute detail to understand exactly what is happening at the community level, to know exactly who the community members are, and not to depend only on the Ministry of Health. The example of Jamaica is that many civil society partners chipped in, but they knew in advance what their role was. And so in that type of environment, you knew that you could depend on somebody to have a vehicle that will be able to transport the nurse that needed to go across the river to attend to someone. This is the level of coordination that is needed. And it extends primarily to persons with chronic conditions because in many cases, they cannot leave their homes. Some of them cannot leave their homes. And so we are required to go to them. And so the coordination is one that is multi-sectoral, but requires a significant amount of detail that in many countries, with all the experience that they've had year after year, I think that they are becoming better in terms of the management, and we can learn from these countries. So my suggestion for a follow-up webinar, honestly, Maisha, is if we can highlight some of these best practices and these success stories at the country level to help us learn, what it is that countries are understanding or what dynamics have changed in terms of what was on paper as part of their disaster preparedness plans and what in actuality they did in response to an emergency. I think it would be super helpful. Over.
Leah, thanks for that. I think it's an important suggestion to move forward. I want to turn to the chat and experiences from the Pacific and highlight a question from an old friend, Dr. Tomo Kanda. And the Pacific, as we all know, shares various similarities. We are all small island developing states. And she says the Pacific has serious workforce shortages, optimization of existing health professionals, especially during disaster, reaching the most remote such as the outer islands, is crucial. Can anyone share any good experiences in the Caribbean to mitigate this challenge? And Leah, this kind of connects to your comment, your closing comment about what are those emerging good practices that we have to document and share and replicate. So workforce shortage, and we know that we have human resources for health as a major issue for us in the region. Anyone want to speak to this, because this becomes even more acute in disaster scenarios? And this can be, David, from a mental health perspective. It can be from a food perspective. Red Cross, Sedima. Anyone want to jump in on this? How do we manage optimization of an already scarce health workforce? Or are there any experiences?
I mean,
I
I
would
can
just jump in.
start if, okay,
Okay.
go ahead, sir.
No, go ahead.
Okay, let's start with Suzanne, then we'll go to Mandela.
Just quickly, some experiences that I know of firsthand, engage in those entities that are within the community and know where people are. So faith-based organizations, social welfare partners, community leaders who know where things are and know where people will be. And one of the things that was very prominent for me here in Jamaica, where we've become so reliant on digital technology and electronics that it took a while for people to realize you need to revert back to, dropping flyers, dropping flyers from a plane, or, so that people know that, hey, go to this clinic or go to the nearest school because help will be there. So it's just understanding maybe not we're in such a technologically advanced setting that maybe we need to sometimes go back to those days where none of those things occurred and people got help.
And over to you, Mandela.
So yes, to speak on this surge support, we know we need support during disaster periods. We cannot do it all on our own. Our staff cannot do it on our own. So we have been working with the disaster mechanisms of the various states to build capacity. I know a number of the entities there have been conducting training workshops, orientation programs and building capacities. And what we have been doing is asking for this list so that we could form regional teams, so that even if we train somebody, say, in Guyana and somebody all the way in Jamaica needs support, it's at a certain standard that we could pull on persons from the non-impacted states and deploy them into the impacted states. And all that, of course, is coordinated through the regional response mechanism at no cost to the impacted state. With regards to health in particular, health is a bit more tricky in that you require a special skill set, I would say. You can't just take anybody, some volunteer saying, okay, I'm a doctor with no background check and deploy that person into an impacted state. Of course, there has to be some screening done, ensuring that the person is who they say they are, that they have the right qualifications. And that's where we depend on our partners. I know, well, I shouldn't say know, Kaf and Power on the line, so they could speak as to how do you pool on personnel across the region and deploy them. So I don't want to speak on your behalf in that field. But one thing I will say, we do support that. We do encourage that. The drawing of persons, qualified persons from across the region, screening and having that list, a pre-identified list of persons who can be deployed. I know that's what we have been working on for the mental health and psychosocial support group and the CAPSEC to identify persons who have been pre-screened in providing mental health and psychosocial support. We have been advocating for this in the health space, and I know it's there, it exists, but I'll allow Paul Kaffer to speak on shed some light on that. Sorry, Leah, for putting you on the spot.
No, thanks so much, Mandela. No, just to complement what you said, it's absolutely correct. This is something that we do support at the national level, so that countries themselves also have their database of persons who can offer surge support at the national level. What we are also proposing and working with CARICOM on is the establishment of a certification model where we can have rosters of persons who can respond to emergencies across countries. So that is also an opportunity. With regard to the question from the Pacific, though, what I understand is a shortage of health personnel also to support moving from one island to the next. And I think that this again goes back to the point that it's not necessarily, well, we shouldn't only expect that the response rests on health personnel, that there are many volunteers, there are many civil society partners that we can work with in advance, preparing them with the skills and tools that are needed to support any type of response. Particularly in mental health, as Maisha mentioned, we have psychological first aid kits. Many countries in our region as well don't have sufficient health workforce or health workforce capacity to respond to every need. And so this multi-sectoral approach is one that we continue to utilize. Over.
Thanks, Leah. And I see David's hand is raised, and then we're going to move to takeaways. Go ahead, David.
Yeah, I would say that one of the things that really worries me or keeps me up at night when I think of disasters is the possibility of multiple islands experiencing some form of devastating impact, in which case the mobilization of some of these health teams could be impacted. And so I think there is an opportunity here for us to build up the capacity internally as well. And so from a mental health perspective, I really want to emphasize the role of training in terms of, even the MH gap training, making sure that our primary healthcare providers are fully equipped to respond to mental health conditions as well. But there's also an opportunity to leverage the support of those faith-based groups, other groups as well, to provide what is usually needed by the majority of the population, which is basic psychological first aid. One of the challenges that we do have, though, is that we do these trainings, we do the capacity building workshops, but we don't keep that database of persons who are certified. And we don't exactly have a mechanism by which we should deploy. And so I think this is one of those areas that we could spend a little bit more time focusing on. How do we mobilize those people, pre-position them at the shelters, at the community centers, etc., to actually show up to deliver that kind of structured psychological first aid and referral onto the services, so that when those teams do come, they could focus perhaps maybe on the more complicated instances, and we have that basic support covered. Over.
Thanks, David. And I'm just scanning the questions, and I want to thank the audience for the level of engagement. We've had so much engagement, questions from the audience and comments and sharing. We've got some questions on protocols and how do we ensure that there are policies and guidance. And I think what we'll do with the recording of the webinar, we will ask all of our partners to share their resources, and we'll provide links on the webpage. And we'll share those with you. There's a question from Dejani J. Wardana, which seems to be, it's around coordination of all of those, the multi-sectoral response. And I think that's something that, we have limited resources in the background, and now faced with these disasters, I think it's something we continue to try to work with and to try and establish best practices. If there are any examples anyone has around sustaining collaboration, that's something that we can share and we'll also put on the website. And I think the last comment, I think that covers most of the questions in the Q&A. And we have a comment here from Naomi Jeremiah about Hurricane Beryl experience, and again with the elderly, saying that post the hurricane, many of the elderly had to be relocated. Almost 100 migrated from Carriacou to Grenada. Many of them were dehydrated and hadn't eaten for days. What policies can be developed to have clear guidelines to prevent such a recurrence? And I would have to assume, Leah, that part of the climate resilience and the protocols and procedures that accompany that are also addressed with dealing, how do you deal with the kind of the basic health needs of individuals post-disaster, including the elderly. So I'm assuming all of that guidance exists. It's just a matter of collating it and trying to ensure that folks have access to it, and continuing the good work of SEDIMA and PAHO and other partners in the Red Cross and kind of the ongoing training. So we're going to move now to our key takeaways. I've asked each of the panelists, and thank you again, panelists, for the fantastic contributions you've made. We value each of your expertise. If you can think of, a maximum 30-second takeaway that you would like to share. So I see Suzanne nodding, so I'm assuming that means she's ready to go. So go ahead, Suzanne, we'll start with you.
Hi, thank you. And yes, thank you again. So just to say, we really have to protect against the threats to our vulnerable food systems, and the whole environment. And we have to look at it at a multi-level, integrative. We have to be flexible. It has to be equity oriented in that way, sustainable. And I can't emphasize timely, because hurricanes wait on no one. So we have to just start and push forward now with what resources we have.
Thanks, Suzanne. And I'm gonna I don't know where Danielle Mullings has gone. I realized that she hasn't been around. And I was so impressed, Danielle, with your presentation, the film you made. So if you have a closing comment, you can tee that up for us. James, because you've just turned your camera on, I'll invite you to give your 30-second takeaway, and then we can go on to Leah, and then whoever else wants to move next, you can raise your hand. So James, over to you.
Thanks. Well, in my takeaway, I'll hark to something that in public health we should be doing more consistently. It was going upstream. What's the cause of this problem? And I couldn't leave this without talking about climate change and the drivers of climate change, the continued use of fossil fuels. And we need, as trusted health professionals, and so we need to make more noise about this because it's bad for your patients anyway. The fumes, the exhaust, the more sedentary lifestyles. Oh, no. So that's what I'd like to flag. Over.
Thanks, James. Leah, over to you.
So for me, I just want to put another building block of a health system on the table, and this is with regard to health financing. We didn't talk about it, but in order for us to have climate resilient health systems, including adapted health infrastructure, we need funding. So we need governments to understand that this is a very important fundamental part of disaster preparedness and response. And so in terms of maintaining a line within the budget that prepares the health system to have everything to withstand future emergencies is important. Over.
Fantastic, Leah. I think an important point for us to keep top of mind. Mandela?
Yes, just want to remind persons that it's all integrated. It's a multi-hazard environment in which we operate. And I know we are focusing on health, but then there are so many other cascading effects. And just want to take a plug there and say, well, at the regional level, we have the regional response mechanism that seeks to bring it all together, all the key partners supporting disaster management, including the work of the health sector, so that we could leverage the resources of the other and optimize the output and the support that we provide to the impacted state. And I do note that we really need to do a bit more in terms of awareness to let people know that this system exists. There are lots of strength to the systems and lessons learned that we are integrating in our processes moving forward. And just to encourage partners and the states to continue to support the system and the mechanism. Over.
Thanks, Mandela. And then we'll go over to you, David, and then we'll go to Rochelle after.
Yeah, I really want to segue from the point that Mandela just left on, which is that idea of communication. I think that we live in an era now of misinformation and disinformation, and so much in terms of health is related to trust. And so if people can trust the systems, they can access the care and support that they need. And so I don't want us at all to forget that we have a duty to communicate now in relative peacetime, but we also have a duty to communicate during and post disaster as well to get the people connected to the support that is so crucial. Thanks.
Thanks, David. And Rochelle?
Okay, just reiterating that we at Barbados Red Cross believe in resilient communities, and these are built before disaster. So once this usually happens through volunteerism, partnerships, preparedness, and once we invest in people and strengthen communities to ensure that no one is left behind, we recover stronger.
Thanks, Rochelle. And let's wrap with, I was told by our Danielle that Danielle Mullings had to leave for conflict. So we'll wrap it with Deborah. Go ahead, Debbie, for your closing takeaway.
Just remind us that we also have very long-term impacts. In Jamaica, we're at the 9-month mark. People are still in substandard housing. Some do not have water in their pipes. Electricity is available in the poles, but their houses are not wired because they were damaged and they don't have the money. And mental health issues are real. I swear that it's only the church is saving a lot of people because they're still meeting in whatever way they can, and that is keeping them going. So we mustn't forget it's not just immediate. Long after the news has gone, people are still continuing suffering from the impact of disasters.
Great, thanks, Debbie. And I want to, before I hand over to Kenneth, just to thank everyone for attending, all of those who attended, and all of the panelists, and a big shout out to our team in the background, led by our policy and operations manager, Danielle, who fantastic work, Janae and Sheena. So thanks to our team as always. And over to our leader, Kenneth.
Thanks, Maisha. And I'm seeing a note that the recording will stop in 2 minutes. I'm not going to be able to get my summary in 2 minutes. However, I shamelessly have cheated and used AI to summarize your thoughts because it was such a rich discussion, right? So the takeaways are AI generated, but the recommendations are kind of human formed. And that's me. I'm the human. So in terms of takeaways, first of all, NCDs do not pause during disasters. Patients with conditions such as diabetes, hypertension, cancer face heightened risks during service disruptions, and this leads to excess mortality and morbidity, and we kind of all know that, right? The second takeaway, unhealthy food bomb. I really like this, Suzanne. The unhealthy food bomb is significant concern to us in the region. Rapid redistribution of ultra-processed relief donations can exacerbate both health issues for survivors and put other people at risk as well. So you as experts have advocated donation guidelines that prioritize nutritional quality. Thirdly, mental health is critical. All right. I know David is on here. Mental health is critical, often overlooked aspect of disaster preparedness. Psychological distress persists long after the natural disaster has passed. And so we need to pay closer attention to that. And of course, Danielle, youth are active leaders in recovery rather than just viewing this as only a victim's. Policies should include them in co-creating disaster response strategies. So I think AI did a pretty good job here. Okay, so now here are the human recommendations. That's from me. Maybe we should integrate health to the center of disaster planning, and governments certainly must prioritize climate resilient health systems. Maybe implement also a cloud-based medical records, which ensures that history remains accessible and we don't have the problem with lost ID cards, etc. Relax prescription refill times in terms of regulations. Utilize confidential community registers to identify vulnerable institutions. And finally, get the messaging right. One of the biggest gaps identified was PR, and we need to do that, especially in times of disasters. How do we get the PR right so that the important messaging about the climate event doesn't kind of totally takes away from those vulnerable people at risk, including people living with NCDs. So that's basically my wrap up. And I just want to hope that this conversation continues not only amongst the panelists and those invited guests, but also amongst you who are our viewers. So here's the question. What role can you play in making the Caribbean landscape more climate health resilient? And what's the one thing you can lobby for such that you move the political determinants of climate health? This has been an exciting webinar. Thank you, HCC. I think, Danielle, I have your permission to close now that we are coming up to that time. Actually, we're over the time. And I look forward to hearing this conversation continue. Everyone, stay safe during this hurricane season. But remember, it's the baseline environment that's more important. How do we get that right? Over.